Yes. So I believe I do not need to introduce Ajay to anybody over here. Amongst all of us, I believe that Ajay is the most knowledgeable and has worked most on different types of positional vertigo. Positional vertigo, as it is the most difficult part of neurology. There are three semicircular canals, and in each of these three semicircular canals, there can be five places where the particles may be lodged. That means there can be 15 types of BPPVs and 15 different types of correcting maneuvers. And that is for one side. You take the two sides, it becomes 30. So there are 30 different types of maneuvers that you need to know and also to recognize by the eye movements and the head position where exactly the particles are. Once you can identify the exact location of the particles, only then you can dislodge them and put them back into the original place. So one of these different types, 15 types of vertigo is sitting up vertigo. And that is not very uncommon, pretty common, especially in tertiary vertigo practice. And all of you who are in the audience today are tertiary referral centers for anything related to neurology, especially neurology included. So that means these difficult cases are the only ones that will be coming to you. Do not think that the posterior canal we will be doing the Dix-Hallpike is the answer to BPPV. So we will hand over the stage now to Dr. Ajay Watts, the most deserving candidate to tell us, to teach us about this. And we have Dr. Sudhir Kothari, Dr. Meenakshi Sundaram, and all the other great people are over here.
Dr. Soumya Sundaram. Dr. Soumya Sundaram. Should I start, sir?
Yes.
I'm going to full slide mode. Okay.
Yeah. Perfect now.
Yeah. So clinical spectrum of the sitting up vertigo. I will be talking about the short arm and periampullary posterior semicircular canalolithiasis and the available treatment options. The conflict of interest, none. Financial disclosures, I don't have to disclose any. I have not received financial assessment from anyone. So this is a diagram which is showing three semicircular canals left in this case. The short arm is here. This is just below the utricle and it is between the utricle and the cupula, posterior cupula. The posterior semicircular canal, as you can see, is the most inferior one, and this is the long ampullary arm. The typical posterior semicircular canalolithiasis is because of the otocorneal debris somewhere here near the posterior cupula, and the rest of it up to crus commune. The rest of the posterior semicircular canal is the non-ampullary arm, a otocorneal clot near the crus commune, as you can see by the red which I have put here, is the apogeotropic variant of the posterior semicircular canal BPPV. And normally this is often associated with a reversible canal jam in that region where it is located. That is why it is being able to be held there, because unless there is some sort of jam, anatomical or physiological. Physiological means a big otocorneal clot in the crus commune region. The otoconia will not stay there. It will either fall into the utricle or fall back into the long arm of the posterior semicircular canal. So with this in background, we are starting our presentation. First 7 to 8 slides will be on few basics about the BPPV, how to diagnose it. The Ewald's law are the laws which were framed by the Julius Ewald around 2 centuries ago, and they bear the name, his name. He applied positive and negative pressures after cannulating the semicircular canals of the pigeons, and he observed the intensity and direction of the generated nystagmus. The two main outcomes of his experiments were the generated nystagmus is always directed parallel to the plane of the stimulated canal. This is the Eval's first law. Second, the generated nystagmus is stronger when the endolymph moves towards the cupula. That is the ampulla, that is the ampulopetal-cupular deflection. In case of horizontal semicircular canals, that is the Eval's second law, and away from the ampulla in case of vertical semicircular canals, that is posterior and anterior. This is the Eval's third law. So this is the ampulofugal and ampulopetal cupular deflection, which is shown here. This is the excitatory ampulofugal deflection, and this is the inhibitory ampulopetal cupular deflection in case of posterior semicircular canals. So you can make it out that in the ampulofugal, it is moving away from the posterior cupula, and it is causing the deflection of the cupula, where the ampulofugal cupular deflection, and petal deflection means it is moving towards the ampulla. So in horizontal semicircular canals, the right one I have shown here, you can see that this is the right horizontal canal, right ear is the shown. The upper row shows the straight ahead supine position. The second is right lateral head roll, and the third is left lateral head roll. So when the otoconia are in the long posterior arm of the right horizontal semicircular canal, and as the patient is made to take a right lateral head roll, there is an ampulopetal excitatory deflection. So there is a geotropic nystagmus which is more strong on right lateral head roll as compared to left lateral head roll in this example. While the opposite is true in case of the canalolithiasis in the anterior arm of the horizontal semicircular canal or in the cupulolithiasis, as the patient's head is rolled to the contralateral non-involved side, as you can say here, there is a ampulopetal cupular deflection, and ampulopetal cupular deflection is excitatory in case of the horizontal semicircular canals. So that's why in the apogeotropic variant of the horizontal semicircular canal BPPV, the side that elicits a stronger nystagmus is the non-involved side, that is the healthy side. So with this, we come to our next example. This is a figure which we often see since our DM times, and we used to read Paul Brazzi's. These are the excitatory and inhibitory projections of the three semicircular canals. The upper row shows the excitatory projections, and the lower row shows the inhibitory projections. And as you can see that if these are the from right-sided canals, suppose we reverse this anterior semicircular canal excitatory projections, instead of right, we do a left one. You can see here. So you can see that the excitatory projections of the left anterior semicircular canal are to the right inferior oblique and left superior rectus. And so also the inhibitory projections of the right posterior semicircular canal are to the right inferior oblique and left superior rectus. What it has to do with the generated nystagmus, that we will come to know in another few slides. So these excitatory and inhibitory projections of the right-sided semicircular canals are shown here. This is the right posterior semicircular canal. The excitatory projections are to right superior oblique and left inferior rectus. Therefore, the slow phase VOR, which is in fact the vestibular phase, is downbeating and left torsional. The positional nystagmus, which we clinically see, is a fast phase VOR and a reflexive saccade. It is therefore upbeating and right torsional in right posterior semicircular canal BPPV. That is the typical variant or the long ampullary arm variant, the commonly seen variant. Likewise, in the inhibitory projections of the right posterior semicircular canal are to the right inferior oblique and left superior rectus. This creates a slow phase VOR, which is right torsional and left torsional and upbeating. Therefore, the slow phase VOR is right torsional and upbeating. The fast phase VOR, that is the positional nystagmus, is therefore downbeating and left torsional. Anterior semicircular canal, the excitatory projections are to the right superior oblique and left inferior rectus, generating a slow phase VOR, which is upbeating and left torsional. Therefore, the positional nystagmus is downbeating and right torsional. The inhibitory projections of the right anterior semicircular canal are to the right inferior rectus and left superior oblique, causing a slow phase VOR, which is downbeating and right torsional. Therefore, the upbeating and left torsional nystagmus is expected in such variant of the anterior semicircular canal BPPV, but this is not possible because to have this combination, you have to have a otoconal debris in the non-ampullary arm of the posterior semicircular canal, which is vertical, and if a clot is there, it will drop down into the crus commune and into the utricle. So practically this combination does not exist. So I am removing this. The third is right horizontal semicircular canal. The excitatory projections are to the right medial rectus and left lateral rectus. This creates a slow phase VOR, which is left beating in the right supine roll test or right lateral head roll. So that the fast phase VOR is right in right lateral head roll, that is the geotropic. In the inhibitory projections of the right horizontal semicircular canal are to the right lateral rectus and left medial rectus, causing a slow phase VOR, which is right beating in the right supine roll test or right lateral head roll. Therefore, the positional nystagmus is left beating in the right lateral head roll, that is, it is apogeotropic. So this is important to know and realize that what we see, that is positional nystagmus, is in fact a reflexive Sicard, and its directions are opposite in polarity to that of the slow phase nystagmus generated on account of the diagram which we had seen on the previous case by the in the article of Adolf Bronstein. So you have to remember that the excitatory projections, that is ampullofugal and vertical canals and ampullopetal in the horizontal canal, and the inhibitory are ampullopetal in the vertical canals and ampullofugal in the horizontal canal. So with this in background, there is one example here. This is the right posterior semicircular canal, inhibitory projections to right inferior oblique and right left superior rectus, and the left anterior semicircular canal, the excitatory projections to the right inferior oblique and left superior rectus. So the slow phase VOR which is generated is identical whether it is right posterior semicircular canal BPPV or left anterior semicircular canal BPPV. Therefore, it is the fast phase VOR, which is positional nystagmus or a reflexive saccade, is downbeating and left torsional, whether it is right apogeotropic posterior semicircular canal BPPV or the more rarer left anterior semicircular canal BPPV. This is a diagnostic dilemma, and now it has been found that apogeotropic posterior semicircular canal BPPV is more common as compared to the anterior semicircular canal BPPV. In my practice, I treat every positional peripheral downbeat nystagmus as apogeotropic nystagmus, follow up over 2 days, see response, and treat it. However, anterior semicircular canal BPPV do exist, and when you do the positional test, one of the positional tests, you do an enhanced head hanging position. When you do that, you complete the Yakovu maneuver during that, and if it doesn't reduces during that time, for all purposes, it is the apogeotropic posterior semicircular canal BPPV. So with this few important slides, I begin my main topic here. This is the patient in whom I treated the Dix sulfide test on the left side shows. I'm unable to play the video somehow. So posterior semicircular canal BPPV subtypes. The first is the typical posterior long ampullary arm semicircular canalolithiasis. The second is the posterior non-ampullary arm semicircular canalolithiasis. The third is posterior semicircular cupulolithiasis or the heavy cupula. Fourth is short arm posterior semicircular canalolithiasis. And the fifth is periampullary canal side restricted posterior semicircular canalolithiasis with partial canal jam. So these 5 variants are commonly seen of the posterior semicircular canal BPPV. The 6th variant is the light cupular, light posterior semicircular cupula, which is mostly post-alcoholic. I'm leaving here for 1 minute because my battery of the keyboard has conked off. Just I will get it changed. So, short arm posterior semicircular canalolithiasis or the graviceptive heavy cupula and the periampullary canalolithiasis with a reversible partial canal jam, the 3 entities which we are going to talk this evening are summarized here. Short arm posterior semicircular canalolithiasis, posterior cupulolithiasis, and the periampullary restricted posterior semicircular canalolithiasis with partial canal jam. All these 3 conditions, of which 2 often coexist, they can cause the syndrome of sitting up vertigo. Originally, it was described by Bela Bucchi in year 2011, where they found that there is vertigo on getting up from supine, anterior-posterior truncal oscillations, and they also documented the posterographic evidence of truncal oscillations on ad hoc posterography, which they did during the Dix-Hallpike testing. So, the Dix-Hallpike test in posterior cupulolithiasis, is this appropriate to do the Dix-Hallpike test during the cupulolithiasis? This is important. This is the Dix-Hallpike position. In neutral posterior cupula, the plane of which is in line with the Earth's vertical during the Dix-Hallpike testing, does not get stimulated. So no positional nystagmus is elicited. So a canal angulated cupula during the Dix-Hallpike test results in inhibitory ampulopetal deflection, generating downbeating contratorsional positional nystagmus of prolonged duration. And the third is the vestibulum angulated cupula during the Dix-Hallpike test results in excitatory ampulofubal deflection, generating upbeating ipsitorsional positional nystagmus of prolonged duration. So, posterior semicircular cupulolithiasis, we do half Hallpike positioning. This is the Dix-Hallpike position. From the upright sitting, we shift the patient head around 120 degrees. So 90 degrees upright, 120 degree at the head end of the edge of the head end of the couch. While in the half Hallpike position, we shift the patient from upright sitting to just 60 degrees. So you can use your hands or you can use the pillow like this. If you keep a pillow which is around 4 to 5 inches thick, the head which is rotated to one side around 45 degrees in the yaw axis will fall on it and will get anti-flex around 30 degrees, making the half alpine position. This is what I routinely do with my patients. So inversion test in posterior cupulolithiasis, whenever you see a upbeating ipsitorsional nystagmus during the half alpine position, it is important to do an inversion test. Why it is important? The inversion test positive means when the right torsional upbeating nystagmus in the right half alpine position becomes left torsional downbeating in nose down to the left. And this is suggestive of adherent type of cupulolithiasis.
Ajay,
Yeah.
can I interrupt? Can you go back? I don't know about the others, but I'm not understanding this. So,
Yeah.
can you just go back and tell us exactly what you did by half alpine?
Yes, sir.
So go back before this.
Sudhir just said what I was also wanting to say.
Yeah,
But then
because Ajay,
feeling a little shy to say.
No. Wait,
So please, okay. Ajay,
the
please,
whole
1
purpose
second.
of today's talk is to understand, because Ajay just blurts out these words. For him, it is like ABCD. But we are not understanding. Huh?
Yeah,
So
I'm going. The Dix-Hallpike test is gold standard for evaluating posterior canalolithiasis.
Right.
So the cupulolithiasis, in which the otoconal debris is stuck or adherent to the cupula, is best evaluated by the half alpine position. So why Dix-Hallpike is not appropriate? Because the posterior cupula has variations. There is a neutral posterior cupula, as you can see here, which in the Dix-Hallpike position remains almost parallel to the Earth's gravity. So it will not be stimulated during the Dix-Hallpike testing, and even if the cupulolithiasis is there, this cupula will not reflect this way or that way. So
let me repeat. So the Dix-Hallpike is for canalolithiasis, right?
Mostly.
And one thing which I want to understand before that is, from the short arm, why don't the particles go back directly from the left? If it is open from that side.
They will go back into the vestibulum. I mean to say
into the
utricle.
Yes.
Utricle. But only the part of the utricle that contains the macula. I mean to say the matrix where the whole of the utricle is not occupied by the gelatinous matrix. So it is only a part of it. So there are instances where you do a Dix-Hallpike test or you do a half alpine test, especially the Dix-Hallpike test. It will fall back into the utricle and it will go and embed into the utricular macula, the matrix, the gelatinous matrix of it. And then you may not see any nystagmus. And this often happens in practice. The patient came to you with complaints of vertigo for past 2 days. You performed a Dix-Hallpike test, and the patient is all right. You call him in the afternoon, another morning, he says, I don't have any vertigo. So probably these are the cases of short-term posterior semicircular canalolithiasis where during the Dix-Hallpike testing, the otoconal debris from the short arm fell into the utricle and got embedded into the macula, that is the gelatinous macula, where it is held back. If it is not, if it doesn't fall into it don't get embedded in, it will again fall back on the utricular side of the posterior cupula. So with that, we are coming to this. This is the diagram is showing a vertical thing, the cupula which is vertical during the Dix-Hallpike position. So if there is a weight on it, it will not be deflected, either ampulopetally or ampulofugally. So there will be no positional nystagmus. The second variation of the Dix-Hallpike test, the second variation is the canal angulated. So the angle of the cupula is towards the canal. So this results in the inhibitory ampuloputal deflection of the cupula during the Dix-Hallpike test. So this will generate a downbeating contratorsional positional nystagmus of prolonged duration. This is the third one is the vestibulum angulated cupula. The Dix-Hallpike test results in excitatory ampulofugal deflection, generating upbeating ipsitorsional positional nystagmus. So what we are doing in half-Hallpike positioning is that we bring the posterior cupula in a position which is horizontal to the Earth's gravity. So when we bring anything horizontal to the Earth's gravity, the cupula will deflect. So understand that. So this is the Dix-Hallpike position which I told. From upright sitting, you are taken to, the head is taken to 120 degrees. And in the half-Hallpike position, it is taken only to the 60 degrees. And here, the posterior cupula lies in the Earth's horizontal. So it has to be deflect.
Okay, 1 minute. Go back to the earlier slide.
Yeah.
So this earlier slide, the one slide before this. Yeah, so this is not half-Hallpike. No? This is the usual Dix-Hallpike.
This is the Dix-Hallpike test. So
that's why I got confused. Okay.
So it gives variable results. The Dix-Hallpike test may give.
No, the next slide.
So this is the Dix-Hallpike test, where upright sitting to 120 degrees. This is the half-Hallpike test.
So now this, wait. Now this, no, I think the slides are, there's a little lag. Go back.
Yeah.
Go back and wait. No, we are not seeing. This. So this slide with the 120. No, that's jumping back and forth. I think there's some lag, Manasi. Now, okay, wait. Just put one slide ahead now.
Yeah. This is the slide.
Okay, but now wait. Now this, what we are seeing, this is the normal Dix-Hallpike, no?
Yeah.
This is not half-Hallpike because upar half-Hallpike likha hai, so I am not understanding.
No. This is not half-Hallpike. This is Dix-Hallpike. I am saying this by making these lines. You can see that from upright sitting, we have shifted the patient to 120 degrees.
Correct.
So the angle from the upright to this is 120 degrees. And this is half-Hallpike.
Next one. The one. This is half-Hallpike. Okay, fine. Now understood. Okay.
Instead of keeping hands and supporting the head, this is 60 degrees.
Correct.
So if you keep a 4 to 5 inch thick pillow at the head end of the examination table, this is the pillow you can see, and and do the Dix-Hallpike test as we normally do, it will land on this, and this will get anti-flips around 30 degrees, making 60 degrees. So this is the half-Hallpike position.
Right. Okay. So means you are going, see, normal Hallpike, you will go 30 degrees below the horizontal.
Yeah.
So here you are going 90 degrees up. So wo 30 plus this 60. So you are going halfway. Correct?
Yeah.
Okay, fine.
So the half-Hallpike position in the posterior cupulolithiasis, it shows prolonged duration upbeating ipsitorsional nystagmus. That is the rule. It will not show anything else. Either it will be present or it will not be present. And if it is present in posterior cupulolithiasis, it has to be the upbeating ipsitorsional nystagmus. So if this is the right Dix-Hallpike position, it will cause upbeating right torsional nystagmus of more than 1 minute duration. So once you see a nystagmus which is upbeating and right torsional, say for example in this case, you do an inversion test. Why the inversion test is important, that we'll come to know in few other slides. The inversion test positive means when the right torsional upbeating nystagmus.
Can you show us how the your diagram of the posterior canal wo in this half-Hallpike position ka hai kya?
That is not there.
But it will be there. The cupula will be 90 degrees horizontal. You are saying, no?
It will be
horizontal.
It will be horizontal to the Earth's plane, and this diagram is there in the article of Professor John Epley of 2000.
Okay. Okay, go ahead. Sorry.
So the inversion test positive means when the right torsional upbeating nystagmus in the right half alpha position becomes left torsional and downbeating in nose down to the left. So this is a adherent type of cupulolithiasis or the true cupulolithiasis. The inversion test negative means when the right torsional upbeating nystagmus in the right half alpha position disappears on nose down to the left. And this is a new concept about which the John Eplin knew 20 years in advance before the Scocco innovated the short-arm posterior semicircular canalolithiasis, where the oculomotor patterns were unveiled for the first time in 2022. So this I am writing cupulolithiasis in inverted comma because this is a dynamic heavy cupula. As the patient gets up from the dix alpine position or is taken to the half alpine position, the free floating articles, they fall on the utricular side of the posterior cupula and causing a dynamic type of heavy cupula that is generating an upbeating ipsitorsional nystagmus of more than 1 minute duration. But when you do a inversion test, it is negative. That is, there is no nystagmus in the inversion position. So this suggests the short arm posterior semicircular canalolithiasis. So sitting up vertigo was, or subjective BPPV first came as
wait, 1 minute. Again, I want some clarification. So when you get a patient with prolonged upbeating and torsional nystagmus, like let's say posterior canal, right posterior canal, torsional to the right side and upbeating, but it is lasting more than 60 seconds, then you have to think that this is either this short arm or the heavy cupula, right?
Yeah.
And then you do the
inversion test.
You do the half dix alpine and you show that you are getting that. Once you do inversion, what you are showing is that when you invert, if the nystagmus direction changes, then that means the particles are stuck to the cupula. Therefore, the cupula now is going to the opposite direction.
Yeah.
Therefore, the nystagmus will also change.
Yeah.
Huh?
And polarity of both vertical component as well as the torsional.
As well as torsional, correct. And if they are not stuck, but they were just floating on top of the cupula in that position, when you put them other way around, they will move away, but they are not stuck to it. So you will not get that inversion or opposite. Huh?
Because if they are not stuck to it, they are just lying on it. When you do
right.
When you do a inversion position, they will fall away. I will show by one animation there.
Okay, great.
So we are coming to sitting up vertigo, the original topic of our talk. The sitting up vertigo or subjective BPPV, as Dr. Vishwas said, is very common. Many patients come to you that I had vertigo on getting up from supine this morning, or yesterday night when I changed side, we took lateral recumbent position. I had a severe vertigo. But when you do all sorts of the positional testing, there is hardly any nystagmus, and we are wondering what has happened, whether it has cured on its own or we are lacking something. So there is an entity which was first described by Bela Bucchi in year 2011. So they found that 20% of their patients with classic BPPV had this. Around 43% had subjective vertigo, no nystagmus, which they call type 2 BPPV. The symptoms, they arose when sitting up from the one dix alpine position, but not from the other side. That is the lateralized symptoms associated with persistent non-positional disequilibrium. So you can see in the diagram here, the B, when the patient was taken to the dix alpine position, it would fall on the utricle, fall away from the utricular side of the cupula and go into the utricle. But it is not yet embedded into the matrix of the hair, which is lying here. So when the patient again sits up, it will fall on the utricular side of the cupula, and there will be symptoms like the sitting up vertigo associated with non-positional disequilibrium. And these authors, Bela Bucchi, etc., they did a ad hoc posturography. They did a posturography during the Dix-Hallpike testing, and it is during that they recorded the postoperative truncal oscillation on sitting up in some of these patients. So now it has come to known as that it is caused by short arm. They also suspected short arm, but some of the short arm cases are associated with the heavy cupula, and periampullary canalolithiasis, that is canal side with a reversible canal jam, can also lead to the sitting up vertigo. So now sitting up vertigo, the spectrum of sitting up vertigo is now expanding from subjective vertigo or type 2 BPPV to short arm with oculomotor patterns on sitting up with positive half Hallpike test with associated with or without associated heavy cupula, and the other entity of periampullary canalolithiasis with reversible canal jam. These are the putative mechanisms as of now. So with this is an important paper. See, the date of this paper is 2001 by Professor John Apley. What did he say? He says that cupula has two potential provocative positions oriented 180 degrees to one another. The earthward direction in one position is stimulatory and in the other position is inhibitory. If particles are adherent to the cupula, the persistent nystagmus will occur in both positions in the same plane, but will reverse direction when the head is turned through 180 degrees. So identification of this nystagmus reversal with head inversion is confirmatory of cupulolithiasis. See the next sentence, how important it is. If the persistent nystagmus maximizes in one provocative position but does not occur in the inverse position, it suggests that the cupulolithiasis may be present due to the non-adherent particles falling away from cupula in one of these positions. So how visionary this great man was, that 20 years in advance he knew that something like posterior short arm posterior semicircular canalolithiasis occurs, and it was in 2022 that Darius Coco, he wrote this paper of 18 patients sitting up vertigo as an expression of posterior semicircular heavy cupula and posterior semicircular short arm canalolithiasis, in which for the first time he documented the upbeating ipsitorsional nystagmus on getting up from the Dix-Hallpike position, and also the inversion test and the half Hallpike position showing prolonged duration upbeating ipsitorsional nystagmus. So this man Darius Coco should be accredited with the unveiling oculomotor patterns of what the people used to say the subjective BPPV. But we'll come to our last slide when we see that still, if I see patients which I have been seeing the oculomotor patterns on setting up from the Dix-Hallpike, many patients still fit in the criteria of the Bela-Bucchi. That is, you cannot find any nystagmus, but the patient still has vertigo on getting up from the Dix-Hallpike or getting up from the supine position. So this appears to be a spectrum. We'll come to on one slide. So this is
Ajay.
Yeah.
I mean, like I used to always think that if somebody has subjective symptoms clinically, maybe it's anything. But if even on re-NG, if you don't see any nystagmus when the person says I'm feeling spinning, I thought most of these patients were either migraine or functional. But what is your finding nowadays? I mean, when you don't see any nystagmus, when the patient is saying I'm feeling spinning, and on VNG also you don't see even one single beat of upward, downward or torsional, do they still turn out to be short arm or whatever BPPV in your findings?
Yeah, I do agree with it. If there is a definite true vertigo, you have to be very sure what the patient is saying. Whenever the patient say कि मुझे चक्कर आ रहे हैं, I always make it out. You define चक्कर. क्या आपको चीजें घूमती हुई दिख रही हैं या सिर्फ घूम रहा है, या चीजें टेढ़ी दिख रही हैं, या आपको झटके आते हैं चलते हुए, लड़खड़ाते हैं आप. I use, if there is a true vertigo, rotational vertigo on getting up from supine and vice versa, then, and if you don't find any nystagmus, and these attacks are short lasting, less than 1 minute, classically, it has to be a short arm posterior semicircular canalolithiasis only, even without the oculomotor patterns.
Okay. Okay.
So
And you have seen them convert. I mean, how do you know they are not migraine?
see, the thing is that you can have vestibular migraine, and one of the variants you can have positional vertigo with that. But they classically have migrainous headaches in between also. It's not that the person with vestibular migraine will not have features of the normal migraine in the other times. So those patients, the things becomes complicated when the patient is young and is having a strong history of migraine. And if the thing is that the subjective BPPV is still an entity which I will in the mass slide will call probable subject BPPV or sitting type 2 BPPV. So it is still persistent, but still you cannot make a clinical diagnosis unless and until you do a posturography. And the ad hoc posturography is not very practical in patients while doing the Hallpike position. You will have to use the apparatus, I think, Carmona showed in 2019. You have got, I think.
Yeah. Okay. So, I mean, because in the other types of BPPV, we can be sure because you do a maneuver and it goes away. But the short arm, you can't even do a maneuver and it will not go away for a few days. No, if I'm not right. Wrong.
Yeah. The only thing is that if you don't find any oculomotor patterns, do repeated sit-ups from the Dix Hallpike position, say around 10 times, keeping the Dix Hallpike position around 5 seconds, 3 times per day, a session of 10 sit-ups from Dix Hallpike position, 3 times per day for 7 days. That was the original Bela Bukki said that it works. So it can work by two things. If the particles are very short, they might dissolve into the vestibulum, or it may fall into it may get embedded into the matrix of the macula. So so some of them they may enter into the posterior canal through the crus commune. So it can convert into the typical variant of the posterior semicircular canal BPPV. So, but the diagnosis cannot be made without the oculomotor patterns. Still, I agree with that.
Okay, please go ahead. Go ahead. Yeah.
So this is the article which came in 2022. The Darius Coco is the main writer from Argentina. And he found his findings were that these were only 18 patients, and he did a set pattern of the positional maneuvers. He did the Dix Hallpike, half Hallpike, nose down. Then he observed the oculomotor patterns on getting up from the Yakamino position. I mean to say the enhanced head hanging position, and he recorded all that. And based on that, he found that 5 out of 18 patients with heavy graviceptive posterior cupula only had short-arm posterior semicircular canalolithiasis. I have abbreviated this as PSC BPPV SA. The second is that 11 out of patients with heavy graviceptive posterior cupula had both short-arm semicircular canalolithiasis as well as posterior cupulolithiasis. And this is another paper from South China where they have used a modified Dix Hallpike position, and they did a bow and yaw treatment initially before starting the repositioning maneuver for the typical posterior semicircular canal BPPV. And they found that 40 out of 170 patients of posterior semicircular canal BPPV had short arm BPPV associated with that. So this is a big number. Around 23% of patients of posterior semicircular canal BPPV had associated short arm posterior semicircular canalolithiasis. So this is another paper on short arm posterior semicircular canalolithiasis. This is our paper from our group. Sudhir is a co-author, and we found that 3 out of 10 patients with heavy graviceptive posterior cupula had only short-arm posterior semicircular canalolithiasis. That is, the half Hallpike position showed that there's a upbeating ipsitorsional nystagmus of more than 1 minute duration with a negative inversion test. And these patients also had the oculomotor patterns of upbeating ipsitorsional nystagmus on getting up from the lateralized alpine position, Dix alpine position. The 2 out of 2 patients, 10 patients had graviceptive posterior cupula, had both short-arm posterior semicircular canalolithiasis and short-arm and posterior cupulolithiasis. Your next question will be, Sudhir, that how did you differentiate between how these patients had isolated heavy isolated short-arm posterior semicircular canalolithiasis and had both short-arm as well as posterior cupulolithiasis. This will come to on a slide.
Okay, so just to tell everybody, if it was only sort of, if it is short-arm cupulolithiasis, then when you do the inversion test, the nystagmus will not reverse. But if it is a heavy cupula, the nystagmus direction, both downward and torsional side also will reverse. Correct, no?
Yeah, the 4 out of 10 patients who had heavy graviceptive cupula, that is posterior cupulolithiasis of adherent type, in all those 4 patients, the Dix alpine test, the half alpine test had right torsional upbeating nystagmus, which lasted for more than a minute, and on the Dix, on the nose down position to the opposite side, the torsional and the upbeating components, they reverse. That is, they become downbeating and torsional to the opposite side. So these were the 4 out of 10 patients. And there is also one thing, or one out of the 10 patients with heavy cupula had both posterior semicircular canal, short-arm canalolithiasis, as well as long ampullary arm, that is the typical posterior semicircular canalolithiasis. Now the next question will be yours, that how did you diagnose the short-arm posterior semicircular canalolithiasis in presence of long ampullary arm canalolithiasis, that is typical arm. So these 2 questions, that is 2 out of 10 patients and 1 out of 10 patients, will be answered as we progress through the presentation. Okay?
Okay, there's one more question. Dr. Booch wants to know, how do you do the inversion test? So do you have a video showing it later?
Yeah, I have.
Okay, fine.
I don't know, because there's something wrong with my keyboard. If that videos don't play, I will make it to the normal mode instead of presentation mode, so that I can play videos from my mouse. Okay. So this is a case 1 with left posterior semicircular short arm canalolithiasis with negative Dix alpine test, but upbeating ipsitorsional nystagmus on getting up from the Dix alpine position. So this is the one. I'm doing it I don't know how to...
No, instead of full screen, make your presentation, escape it and make it half normal. Instead of full screen, press escape.
I'm doing that, but I'm not able to do it. I don't know why. Should I log out? I should stop.
No, don't log out. Your
PowerPoint. I have stopped the screen share. Share it.
Go to your PowerPoint.
Yeah. This is the left Dix alpine test.
Wait, you have stopped screen sharing, so we can't see.
Okay. Screen share करेगा. Please screen the share. Do it. इसको minimize करके करते हैं एक बार just.
Is it playing when you on your computer?
Yeah, it's playing on my computer.
Okay, then just share the screen and try again.
Yeah. Okay, this. Can you see now? Is this?
Yeah, we can see.
Now play. Yes.
Yeah.
Yeah.
So it is the left Dix-Hallpike position. The no positional nystagmus is seen. I will keep it for full 40 seconds. Absolutely static eye. Just try to see the left eye because the left side is more clear. There's some problem with the right side. So she was made to sit up and very subtle, just concentrate on the left side, on her left eye. You can see a very subtle now it has started.
Upbeating and left torsional. Yeah.
Of variable intensity, but there is a subtle nystagmus which is upbeating and left torsional.
And does she have symptoms while she's getting this?
Yes, she was symptomatic and she had to be supported with my hands because she had some oscillations also.
Okay.
Although it is very crude to say that you can appreciate the things which we note on the posturography, but there is a definite nystagmus.
So this is the poor man's posturography.
Yeah. So her half-Hallpike test as well as the Dix-Hallpike test were all negative, and only there was a subtle nystagmus on getting up from the left Dix-Hallpike, not from the right Dix-Hallpike. So coming to our next patient.
Was this right torsional or left torsional?
Left torsional. It was left torsional. So the second case is a typical right posterior semicircular canalolithiasis associated with short arm posterior semicircular canalolithiasis. Again, I am showing it here. This is a 42-year-old lady. You can see a upbeating right torsional nystagmus. I performed a Dix-Hallpike test hand in hand. Once I saw that it is lasting less than 1 minute, I performed the Hallpike test, the Applet maneuver hand in hand. So it is dying down, and in less than 1 minute it has gone. So now I take her to the position number 2. So this is the position number 2. You can see again a nystagmus which is upbeating in the position 2 of the Applet. So this is a good sign. If there is a downbeating nystagmus in this position, the Applet usually fails. So I was very happy that this patient will not have any residual dizziness when I see her next day morning.
What is the third position?
Third position is the nose down to the left lateral recumbent with nose down. This is the position 2. So this is the position 2. Then this is the position 3. The recording is taken from the ground, someone on the ground. And then she was uprighted to short sitting, completing the Applet maneuver. This is the upright sitting on completion of the Applet maneuver. So next day, this lady returns with a residual dizziness, and naturally I did a Dix-Hallpike test once. No nystagmus, right Dix-Hallpike do not show any nystagmus. Because I had just read that paper from Darius Kokko I recorded the oculomotor patterns on getting up from the right disulfide position, which I will show in the next slide. So, on getting up from the right disulfide position,
Ajay,
yeah,
sometimes when we are doing a posterior canal repositioning, in
just see
one of
the nystagmus.
yeah, sorry.
Just see the nystagmus. She has got a upbeating
And
right
right
dorsal
torsion.
list.
Yeah.
Now you speak, sir.
No, sometimes like in this patient, in the earlier thing, in one stage you get a horizontal nystagmus. What does that indicate? Means normal Dix Hallpike you should get upbeating, torsional, and continued, or then later in the third stage you get downbeating. But sometimes you get horizontal, but it has not got converted into a lateral canal. So every time it becomes horizontal, I am worried that have I pushed it into the lateral canal? But sometimes that doesn't happen, and yet you get a horizontal one. Do you find that sometimes, or
Yes,
Anirban?
I sometimes find in one of the patients with pupillolithiasis, which I managed around 4 years back with multiple maneuvers. Successfully they did. I found a horizontal nystagmus, a vertical nystagmus in patients with horizontal canal BPPV. So actually, this could be because of the abnormal anatomy.
Anatomy. Okay.
So
Now this patient, you had a typical posterior canal BPPV, which you reposition, and next day it looks like it is a
short arm as well.
short arm. So it can't be, those particles cannot go from the long arm to the short arm. So that means they were there.
There is a posterior cupula. There is the cupular barrier.
Yes.
So I was inclined to do a half Hallpike maneuver before I started doing with the pillow of 4 inch thickness. I was doing it like that. This was my first patient in which I did a half Hallpike maneuver.
I have one more query.
Yeah, I'm stopping that.
While you are doing, sorry. Yeah.
You start.
So, is there any possibility that from the right posterior canal, it went into the right anterior canal, some particles?
So if it goes to the right anterior canal, how is that possible? It will go to the right anterior canal during the apply maneuver.
Yes, some because same side particles. I'm just saying that you are getting an upbeating nystagmus, which you would get in anterior canal.
Normally, the upbeat the nystagmus of the anterior semicircular canal does not reverse directions when patient is taken up from the Dix-Hallpike position. And this is also true for the apogeotropic posterior semicircular canal BPPV. In all the papers which I have read about the anterior semicircular canal BPPV and apogeotropic posterior semicircular canal BPPV, the nystagmus direction reversal on getting up from the Dix-Hallpike doesn't happen. So that possibility is ruled out in this case.
Okay.
So when I found a upbeating ipsitorsional nystagmus on this patient, I did a half Hallpike maneuver, and I had to use my hands to give a 60-degree inclination. So just
you're going to show the inversion. You're going to show the inversion.
Lack of inversion.
Okay, but the inversion test you will see now, Dr. Buch.
Yeah. So this is a inversion test. I will bore you for another 1 minute and 47 seconds. I will show you the full nystagmus. You can see the nystagmus which is upbeating, and definitely it is right torsional.
It is going on for more than a minute.
It has not gone. At 1 minute and 47 seconds, I will do a nose down. So I am scrolling it to around 1 minute and 30 seconds. This I have scrolled now. So you have another 17 seconds before I do a nose down test. That is inversion test. So this is the right half Hallpike position. Her occiput is supported on my hands. And at 1 minute and 47 seconds, now I am going to do a nose down. This is the nose down position. The nystagmus has disappeared. Can you make out this? There is no nystagmus. Can anyone appreciate any nystagmus?
No nystagmus. So this is not cupulolithiasis. This was short arm.
Yeah. But half alpine test shows a prolonged duration nystagmus of more than 1 minute and 47 seconds. If I had maintained the half alpine position, it would have been even longer. So how this happens, I have shown by this diagram. A shows the sitting, the B shows the half alpine position, and C shows the nose down to the left. So here it is a deflection which is ampulofugal here. And as the patient is taken to the nose down position, these particles, they fall away from here. Corticonia, they fall away, and there is no cupular deflection. Okay.
So D is the heavy cupula, means the cupulolithiasis, and E is the short arm wala.
No. This is in the short arm, but they are not adherent. And
Okay,
E,
they are not adherent.
And E, because it is nodes down to the, so they will gravitate and fall away. So if they are gravitate and fall away, there will be no cupular deflection.
Right. Okay.
So the case 3 is right posterior cupulolithiasis with inversion test. So this is a 61-year-old patient. Playing the video from here. At least 1 minute you will have to see to believe it that it lasted for one minute. Okay. You see first 2 downbeats, and now you can see the upbeating nystagmus, and clearly it is right rostral. You can see the lights of the videoculograph which is beating towards right, and you can see the torsional component also towards the right, in the right half alpine position.
Oh, this is half alpine. This is not Dix alpine.
No. You remember, Sudhir, we do inversion test from the half alpine position.
Yes.
And the sitting up oculomotor patterns, we always and invariably we see from the Dix alpine position, because in the Dix alpine position, the particles, they fall away from the utricular side of the posterior cupula, and you make him sit, it will fall back again on the utricular side of the posterior cupula, making it heavy. In the Dix half alpine position, they are already falling on the utricular side of the posterior cupula, causing this type of nystagmus. Now 1 minute has occurred. I did a inversion test at 2 minutes. So this is now I am doing inversion test in this patient. From the half alpine, you can see that there is a pillow of around 4 inch thickness, and now there is a inversion of the nystagmus. Can you make it out?
Downbeat we can, but left torsional we can't.
Just see the upper poles of the eyes, especially the left eye, patient's left eye.
Okay, now, yes.
So you can appreciate the torsional. It was right torsional upbeating in the half alpine, and in the left, nose down to the left, that is the inversion position, both the polarities have inverted. So this is a case of posterior cupulolithiasis, adherent type of cupulolithiasis. He did not had any oculomotor patterns on setting up from the Dix alpine position. So why I have shown here? Because many patients with posterior cupulolithiasis have associated short-arm posterior semicircular canalolithiasis, and how to differentiate them will be seen in another patient, the next patient. So should I carry forward this slide?
Yes. Are you going to tell us about treatment of these patients also later?
Yeah.
Okay.
Posterior cupulolithiasis. It does not respond to Apley maneuver or Simon's maneuver. There are anecdotal reports from few colleagues that they did a rapidly positioning with Simon's and they found it was effective. But I did in every patient, it was not effective.
What about vibration?
Yeah, I also tried vibration with a vibrator which is used by the David Z. But it did not work also. I did head shaking also. I did Brand-Daroff therapy treatment for one full session for one day. It did not work. So what I do is send them home with a video of Brand-Daroff treatment after performing on them for one day, one session. So after 30 days, they are usually asymptomatic and have the disappearance of the oculomotor patterns. So, but this is how is the natural history of the patients also. If you don't do anything, they will recover in a period of 4 weeks. And this is from a paper of recently 2022 only. So the next case is right posterior semicircular cupulolithiasis with weakly positive inversion test. So weakly positive inversion test means the inversion nystagmus was not as robust as it was seen in the half Alpine position. And this is the next patient. This is a lady around 50 years, had vertigo for around a week. I am doing a half Alpine position. You can see that her head is landing on a pillow of 4 inch thickness. So again, you will have to bear with me to see it to at least 1 minute. This is a 2-minute nystagmus. Can you make it out that it is upbeating and right torsional in the right half Alpine position? Is that clear to everyone? Very robust nystagmus in the half Alpine position. Scrolling up to 1 minute and 38 seconds, it is still present. Scrolling to around 2 minutes, it is still present. Now at this moment, I do a inversion test. From the right half Alpine, she is positioned with nose down to the left. That is left lateral recumbent with nose down. Again, you see inversion of the nystagmus. The nystagmus has become downbeating. And you can see a torsional component, which is to the patient's left. See the right eye now. The upper pole of the right eye. You can see that the torsional component is beating towards the patient's left. Can you make out, Sudhir?
Yeah, it is seen.
But notable to see is also that the half Alpine position was showing a very robust upbeating right torsional nystagmus. And in the nose down to the left, it is not as robust as it was. The strength is not as robust as it was in the half Alpine position. Can you make out that?
Yeah, so I mean, if it was equal and opposite, then we say it is cupulolithiasis. Now, what are you saying?
Yeah, yes, it is still a cupulolithiasis, is still present, but because the nystagmus has attenuated, so it means that the heavy cupula was in part due to cupulolithiasis and part due to short arm, and in the inversion position, the particles which are non-reiterant, they fell away, and so they made this nystagmus less robust.
So, I mean, that's a very nice thing. That means you have got 3 grades now.
Yeah.
So, one is completely reversal, equal reversal is cupulolithiasis. Yeah, no reversal is short arm. and this is halfway.
Yeah. So I did a Dix-Hallpike test. Why did I do a Dix-Hallpike test? First, just to see what type of cupula it is. It is possibly a vestibulum angulated cupula. That's why both Dix-Hallpike as well as the half-Hallpike are showing prolonged duration upbeating right dorsal nystagmus. And second, I had to check up the oculomotor patterns on sitting up from the right Dix-Hallpike position. You can see now again it has become as robust as it was seen in the right Dix-Hallpike position. Can you make it out now?
Yeah.
So now I will scroll it up to show you the oculomotor patterns on getting up. See, this is the oculomotor patterns on getting up. You can see the upbeating nystagmus on getting up.
But mild.
Yeah, but this is because of the associated and additional short arm posterior semicircular canalolithiasis of right side which was present on this. So it is important to see the oculomotor patterns on sitting up from the Dix-Hallpike position, not the half-Hallpike, in patients suspected to have short arm posterior semicircular canalolithiasis. So this is what this.
Can you explain this once again? What exactly you did? Why sitting up from the Dix-Hallpike and not short arm and not half-Hallpike?
Because in the half-Hallpike position, the cupula is already horizontal to the Earth's gravity, and the particles in the short arm, they fall to the uticular side of the cupula. In the Dix-Hallpike position, they fall away from the uticular side into the cupula. So it is the half-Hallpike position which is useful in assessing short-arm posterior semicircular canalolithiasis, not the Dix-Hallpike test. And the sitting up from the Dix-Hallpike is useful, but not the Dix-Hallpike itself, the head-hanging position of the Dix-Hallpike. Is that clear?
Okay,
so this is the thing, and this is the paper which we have did.
The last one, yes, I know.
Yeah, the panel A, the row shows that this is a inversion test strongly positive. Here it is a strong ampulofugal cupular deflection. Here this is a strong ampulopetal cupular deflection in the nose down to the left in the row A. In the row C, come to the row C. The inversion test is negative. These are the particles which are not adherent. They are lying loose on the uticular side of the posterior cupula, and they fall away from the posterior cupula into the short arm, and there is no cupular deflection. That's why the inversion test is negative. The B is the grade where the heavy cupula is caused by the particles which are shown in the red, which they are short arm, and the heavy cupula by the green, which is shown here. So as you do the nose down position, the particles which are free floating in the short arm, they fall away, but the cupulolithiasis is still there. So inversion test will be still positive, but it will be attenuated. So this grade is mildly positive, weakly positive test. Okay.
Yeah. So this slide is excellent, and I think Dr. Buch, this shows you how he's doing that inversion test. Also, you can see the 180 degrees turn of the head. Yeah. Okay. Very nice.
You see, from a picture part, things appear very clear. From this thing, so this appears clear. But the thing is that whether they tally so much clinically or not, and whether all these things can be picked up just by the video frenzel. So that is something
picked up by the video frenzel, but after all, this is a hypothesis. Yeah, you cannot prove it, but this is logically what looks like.
Yes, this is the logical explanation. Let's put it that way.
Yeah, that's a logical explanation. I analyzed each and every video multiple times before publishing this paper. This paper is recently out, only a couple of weeks back. So I examined each and every video multiple times during its making. So that was my impression from this. And when I found that there is a attenuation, I did the sitting up from the Dix-Hallpike position. So suppose in the previous question, if I have found that the patient has got the half alpine showing prolonged duration of beating right dorsal nystagmus and inversion test is positive, there was something to suspect that I should also do a oculomotor pattern, so sitting up from the right disc alpine. So I did a right disc alpine and found that there is a associated short arm posterior semicircular canalolithiasis also. And then I again went back into the video and saw that there is a attenuation of nystagmus in the right disc alpine from the right half alpine position to the inversion position. So that's how the hypothesis was created.
Yeah. This is quite
So that makes
mathematical.
sense.
I think the whole thing is very much
100% logical.
Yeah, very much mathematical. I think it's excellent. Geometry plus mathematics.
Yeah, so see that paper, the article from Dario Scocco is a wonderful article. I have not seen such an article in recent times on BPPV. That was a thought-provoking paper, and he did all these things in that paper. And it's very difficult to understand. Scocco has made a video also on the YouTube of that. I have to see that video multiple times to understand his hypothesis. So this is how I just found out almost half of the cases, exactly 9. Now there are 10. Only 9 are reported of these combinations. So this is the case 5. This is the short arm posterior semicircular canalolithiasis, query half cap with upbeating ipsitorsional nystagmus and negative DST and HST. Here the half alpine test is also negative. So this is the case history of the patient. This 57-year-old male patient presented with 2 days history of vertigo and getting up from supine. Neurological examination was normal. The otoneurologic examination was as under. Left disc alpine, no positional nystagmus. Oculomotor patterns on sitting up from the left disc alpine, upbeating left dorsal nystagmus of prolonged duration. Left half alpine position, no positional nystagmus is elicited. So he was ostensibly treated as left short arm posterior semicircular canalolithiasis with multiple sit-ups from the left disc alpine position, and every time the head hanging position during the disc alpine position was maintained for 5 seconds. So I am playing this video. This video you have to see in full to appreciate what happened. This is around 5 minutes video. Left disc alpine test, no positional nystagmus is elicited. Absolutely static eyes. This is a very important.
And no symptoms also.
There were no symptoms also.
Is there slight downbeat? Is there slight downbeat?
No, sir. No, sir. I don't see. He is made to sit up from the left disc alpine. After 10 seconds, you see in the nystagmus. Can you see it now? It has begun. See the left eye of the patient. You can clearly make out a upbeating left dorsal nystagmus.
Ajay, can you send me this video later? I think there is slight downbeating, though it won't change anything, but still, let me just check.
I will share the YouTube link of this video.
Yeah.
But can you make out this a definite upbeating left dorsal nystagmus here?
100%, yeah.
And you can also appreciate that it lasted for more than 1 minute. Normally, it should not last for more than 1 minute in the sitting up position.
Yes.
This was again an oddity in this patient. So I did a half Alpine test to know whether it is a short arm or not. I don't see any nystagmus in the left half Alpine position. No nystagmus in the left dix halpi, no nystagmus in the left half halpi, but getting up from the left dix halpi elicits a upbeating left torsional nystagmus of prolonged duration. So my interpretation initially was left short arm posterior semicircular canalolithiasis. This is the maneuver suggested by the Bela-Bucchi. Repeated sit-ups from the dix halpi position which has symptoms. It has a sign also. 3, I did 10 times. Depending on the suppleness of the cervical spine, you can do it fast or you can do it slow. In the normal course, when I see such patients without any oculomotor patterns, I usually send them home with a video of this. I record their video and I send them that you do this because it is easy to be done for 7 days, 10 times per session for 3 sessions per day for 7 days. But in this patient, because I found a oculomotor patterns of upbeating left torsional nystagmus on getting up from the dix halpi position, I made a follow-up at 24 hours with, and on follow-up, the left dix halpi test elicits a upbeating left torsional nystagmus in the left head-hanging position, as you can see in the video which is coming very soon. Now it is clear. Left dix halpi showing left torsional upbeating nystagmus of typical posterior semicircular canal BPPV. So what has happened? How did the patient had the putative short arm posterior semicircular canalolithiasis with classical patterns of upbeating ipsitorsional nystagmus on getting up from left dix halpi, and now he has got a otoconal clot on the other side. The free floating otoconal debris in the descending portion of the periampular portion of the left semicircular canal, it encounters a ampulofugal restriction, either a large debris size or a anatomical reduction in the semicircular canal diameter. This is the animation you can see here. This is again by this is the Skokos 2019 hypothesis. This is the constriction, no dix halpi, no oculomotor patterns, and on getting up from that, due to gravity, there is a ampulofugal cupular deflection and you get the typical upbeating nystagmus. So this is on the other side of the cupula in the periampulary restricted. So this is a periampulary restricted left posterior semicircular canalolithiasis with partial canal jam in the periampulary region, either a large otoconal clot or a structurally narrow short segment of the posterior semicircular canal functioning like a low pass filter. This is the Skokos 2019 hypothesis of the setting of vertigo. So what happened in this patient is hypothesized in the next diagram here. So this is the sitting position. This is the dix halpi position. I have shown right in this case, although patient was on this side. This is just for to clear the concept. So when you see this diagram is here. I made it big here. Okay. So this is a periampulary. There is some restriction here, either a large clot or a anatomical restriction. So when you do repeated dix halpi test, you do multiple sit-ups from the dix halpi position, the otoconia, they break away. See, the otoconia have broken away and now they are able to pass through the low pass filter. So this patient was treated with quick liberatory maneuver. He did not respond to the Epley maneuver once. So I immediately recognized that there has to be some anatomical jam here in this region. And still, if you do a fast maneuver, the quick liberatory maneuver, you position the patient to the dix halpi position, and then within 1 second, you take it to the nose down position to the left side. That creates a inertia, and because of inertial forces, you are able to take up this jam. I did 5 quick laboratory manual and called again in the afternoon. And in the afternoon, he remained vertigo free, and he remains vertigo free till date. So this is the ampullary arm. So again, I am showing a video here. The periampullary posterior semicircular encounters an ampulofugal restriction of the movement during the Salpike test. Large debris size or anatomical reduction in the semicircular canal diameter, creating a otolithic jam. So first, there is a negative inertia, and second, there is a gravitation. And because of the gravitation, there is an ampulofugal pupillar deflection. So this also causes identical oculomotor patterns which are identical to the patterns which are suggested by which are caused by the short arm posterior semicircular canalolithiasis. And the two things are very different and very difficult to differentiate. The only point which favored that this belongs to this category, that is the periampullary restricted posterior semicircular canalolithiasis with associated jam in the region, was that it converted into the typical posterior semicircular canal BPP. So that is how the diagnosis was made. Otherwise, my first diagnosis was short arm posterior semicircular canalolithiasis only. So the posterior semicircular canalolithiasis is here because most of the videos have just finished. I think that was the last case. So
1 minute. That means this case. Wait a minute. Go back.
Yeah.
1 slide back.
Yeah. This is the video.
That animation slide.
Animation slide is this.
Next slide. That's Coco's. This one. So here you are showing. The earlier one. So that Coco ka slide jo hai, where there was a narrowing and the particles were sort of stuck there.
Yeah.
And now in this figure, that narrowing has gone. But actually, in your case, because you did repeatedly, they went past that narrowing and got into the long arm. And that's why it turned into a normal posterior canal BPPV.
Yeah, because we did a multiple sit-ups on the left Dexalpine position. So the particles, they become smaller. This is our hypothesis that they become smaller and they were able to pass through a low pass filter. So right. That's what I have seen in the diagram there.
Yeah. So they came towards the left. That means they got into the long arm.
Yeah. So they went away from they passed the periampullary jam.
Right. Okay. Great. Very nice.
So now the posterior semicircular canal BPPV, I am now going to the full slide because now I have to show this. So this is now summed up here. The core features are subjective BPPV, type 2 BPPV, sitting up vertigo, non-positional disequilibrium, no nystagmus on positional tests, abnormal truncal oscillations during and after sitting up. These are the descriptions of Bucchi 2011. Now, as the time passed over the past 12 years, several things came. Half Alpine test showing upbeating ipsitorsional nystagmus of 60 seconds with negative inversion test. That is, some of these patients will have more than 60 seconds upbeating ipsitorsional nystagmus with negative inversion test. This was first shown by Scocco in 2019, later in 2022, and by us. So our paper, in which we documented this. Some of these patients had upbeating ipsitorsional nystagmus on getting up from the lateralized Dexalpine position. Another thing is that half alpine position in some of the patients, they show more than 60 seconds upbeating nystagmus with positive inversion test. It means that the posterior semicircular cupulolithiasis was associated with it. That is, it was associated with the short arm posterior semicircular canalolithiasis. And many of these patients had upbeating ipsitorsional nystagmus on getting up from the lateralized Dexalpine position. That means the two conditions existed as occurred in one of those ladies in which it was attenuated. And some of the patients, they had converted into typical posterior semicircular canalolithiasis, especially they had residual dizziness after typical posterior semicircular canal lesions, and they can be attributed to the residual symptoms could be attributed to the short-arm posterior semicircular canalolithiasis. Is that clear?
Very nice. Just one caveat: if you get somebody with subjective BPPV, that is positional, they get symptoms, but if you don't see any nystagmus, you should be very careful. Sometimes they can have a lesion in the posterior fossa. I have seen a couple of tumors in the posterior fossa where they get symptoms, but no nystagmus is seen, no upbeating, no downbeating, no nothing, and then they may have. So if somebody has what looks like BPPV, that is positional nystagmus on sitting up or lying down, but you don't see anything, you should be very careful.
Yeah, especially if it is apogeotropic horizontal canal or it is downbeating.
Yes, yes.
So downbeating is a very different thing. And recently, in one of my patients with apogeotropic horizontal semicircular canal BPP, which did not responded to the Zuma maneuver, I did a MRI and I found a tumor in the lateral wall of the fourth ventricle. So it was a central paroxysmal positional vertigo. He had typical vertigo. He had Bowen lean test was typical. The apogeotropic nystagmus reversed direction, but late there was some delay in the lateral hold to the other side. So immediately I got a MRI done, and that showed the tumor. So this is possibly my last slide. We had talked about the posterior semicircular canal, this short-arm posterior semicircular canal. Now this is the important diagram. These are the short-arm posterior semicircular canalolithiasis. Okay. So as the patient is made to sit up from the dix alpi position or is positioned to the half alpi position. See, the two are same. Sitting up from the right dix alpi in this case or the right half alpi position will make the otoconal debris fall on the utricular side of the posterior cupula. So this is a dynamic heavy cupula of the SCOCO described in 2019, 2022. Here, the inversion test is negative because these particles are not adherent to the utricular side of the posterior cupula. But you will get a updating ipsidorsal nystagmus on getting up from the dix alpi test. Suppose the particles are very small, like this. You can see their movement, and they are chronically deflecting the posterior cupula. This is the type 2 BPPV of Bucchi 2011 and 2014. Short vertigo spells retropulsion, anteroposterior truncal oscillations, and non-positional disequilibrium. And the third is the
Wait. How do you treat this? Dix, you just advise Branderoff at home?
You can short-arm posterior semicircular canal ulysses. You can do the Branderoff, or you can do the repeated dix alpi from the lateralized dix alpi position. That is the alpi position that elicited the symptoms, but without nystagmus. So the third variation is the posterior heavy cupula because of adherent cupulolithiasis, which Apley said in 2001, where the inversion test is negative. So this is the diagram which I have made to explain this. Can you make it out, or should I make it again?
Yeah,
Right.
this is fine. Yeah, this is fine.
Okay. So with this, the treatment options, this is possibly our last slide, is repeated sit-ups from the dix alpi position. That is the alpi position that elicited the symptoms of positional vertigo, which we did in our last patients 10 times per session for 3 sessions per day for a week. This is one of the options.
Yeah, for Dr. Butch, who's asked, you can ask the patient to do the dix alpi at home, give them a pillow, and ask them to do home Epley or dix alpi at home. Not Epley, sorry. The dix alpi, as what Dr. Ajay showed, he's doing it up and down repeatedly. You can ask the patient to do it at home.
And the head hanging position should be maintained for around 5 to 10 seconds every time. The second is bow and yaw maneuver, has come in the paper by Ping, which I had shown, in which 40 out of 170 patients had associated short-arm posterior semicircular canal lithiasis. But this maneuver is slightly difficult to do in patients who have osteoarthritis of the knee and those who are obese. So you have to bow like you offer namaz, then you have to move your head side to side in the yaw plane for multiple times. So this is practically, I've tried in many patients with suspected, but I found it difficult to take a position in which they can do it. I have YouTube video on my channel. You can see that bow and yaw maneuver. If you write bow and yaw maneuver, it will go to that YouTube section. And third is the Brand-Daroff exercises. They need, which I usually advise, home-based for around 1 month. So most of the patients of a short-arm posterior semicircular canal lithiasis, they respond within a period of 4 weeks, and this is the time actual for the pupillolithiasis also. So sitting up vertigo, posterior semicircular canalolithiasis, the core features we had said, again repeating: subjective BPPV, sitting up vertigo, non-positional disequilibrium, no nystagmus on positional test, abnormal truncal oscillations during and after sitting up. Some of these patients have half Alpine test, which is positive with upbeating nystagmus of more than 60 seconds duration with negative inversion test. Some patients have upbeating ipsitorsional nystagmus on getting up from the lateralized disc alpine position. And some of these patients have half alpine test eliciting UBITN of more than 60 seconds with positive inversion test. That is, they are associated with the posterior pupillolithiasis also. The second sitting up vertigo arm is the periampullary posterior semicircular canal lithiasis with partial canal jam. The last patient which we had seen, in which I had done multiple sit-ups. So same symptoms as the canal short arms semicircular canal lithiasis, but I have not found any literature where there is any posturographic evidence of truncal oscillation, because Skoko, he did not do anything of that sort in his paper of 2019 or 2022. So some of these patients, they may convert into posterior semicircular canalolithiasis, attesting the theory that the otoconal clot is towards the canal side of the posterior cupula, not to the utricular side of the posterior cupula. And this is exactly which happened in our patient, in which we did the multiple sit-ups. Although again, multiple sit-ups from the disc alpine position is meant for short-arm posterior semicircular canalolithiasis, but not for this variant of periampullary posterior semicircular canalolithiasis with partial canal jam. But we did, and we were successful in converting it to the posterior canalolithiasis. And this is what exactly Skoko wrote in 2019 paper, that some of these patients, they convert into typical posterior semicircular canalolithiasis. That's why I have put on this hypothesis. So when some of these patients have typical posterior semicircular canalolithiasis, this is the last animation. When you find a residual dizziness, again suspect associated short-arm posterior semicircular canalolithiasis as occurred in that female, the second patient which we had seen. That was the first patient to be seen and identified by me. So the proposed criteria for short-arm posterior semicircular canalolithiasis, that we can name by the name of Sudhir or Anirban sir, by the Anirban's criteria or Sudhir's criteria.
No, Ajay's criteria. What's criteria?
You people are seniors, so you deserve to it. The probable is sitting up vertigo, non-positional disequilibrium, and anterior-posterior truncal oscillations during and after sitting up. This is the probable, where you don't see any nystagmus. The second is possible, one as above plus any two of the following: upbeating ipsitorsional nystagmus on getting up from the lateralized disc alpine position. Half alpine test elicits upbeating ipsitorsional nystagmus of more than a minute duration with negative inversion test. Ad hoc posturography in sitting position shows abnormal truncal oscillations. If any two of the following three are present, you can say it is possible short-arm posterior semicircular canalolithiasis. And the definite is when all three, the number one as above plus all three of the following are obeyed. So this classification, I think, Sudhir, you can propose because you are a member of the Berenice Society. During the Berenice Society meeting, you can propose this.
I think what we'll do is let me send this to Dr. Asprella and at least get it published in their journal. Let's get to it. I'll first send him the videos and this whole thing. The last case.
I will share the whole presentation with you today.
Yes, yeah.
So,
great.
Coming to the flow chart, the Dix-Hallpike test, upbeating torsional nystagmus of less than 60 seconds. It means typical BPPV, long ampullary arm. Treat with apnea maneuver with follow-up positional test, retest at 1 hour and 24 hours. That's what I do in my clinic. You can pick sitting up vertigo, oculomotor patterns at these moments. If the patient has residual dizziness, you see sitting up oculomotor patterns after doing the repositioning at 1 hour and 24 hours. And in many patients, you will find out associated short-arm posterior semicircular canalolithiasis. The second is upbeating ipsitorsional nystagmus of more than 60 seconds duration. Do a half-Hallpike test. Again, you find a upbeating torsional nystagmus of more than 60 seconds. Do an inversion test. Inversion test is positive posterior cupulolithiasis. Treat with Brand-Daroff exercises for a month. The YouTube link for doing it is there shown. If the inversion test is negative, then treat it as short-arm posterior semicircular canalolithiasis. You can do repeated sit-ups from the multiple sit-ups from the lateralized Dix-Hallpike position 10 times per session for 3 sessions per day for 7 days. Or you can proceed to Brand-Daroff exercises. See, ultimately it will go away in 1 month only. So the other thing is that you have a negative Dix-Hallpike test, but sitting up vertigo with upbeating ipsitorsional nystagmus on sitting up from the Dix-Hallpike position, you do it half-Hallpike position. It could be short-arm posterior semicircular canalolithiasis still, or it can be periampulary restricted posterior semicircular canalolithiasis, partial canal jam, that thing which we showed in the last video. And in our video, it worked with multiple sit-ups from the lateralized Dix-Hallpike position, although it has never been reported earlier. So this we had reported in one of the letters to the editor. So this finishes my test. Now the torsional downbeat nystagmus. This is the last thing, and one of the videos which I could not show. I will try to show it now. Treat it with quick liberatory rotational maneuver or forced prolonged position of 2015 of Vanucci or demi-cement maneuver for the side opposite to the direction of the torsional component of the with follow-up positional retest at 1 and 4 hours.
This last one is apogeotropic posterior canal.
Yeah. That video I will be showing, which was not played earlier, because this finishes our presentation here. So I am going in the normal mode. The video, this is interesting because I had started picking up the posterior canal apogeotropic cases only after I started using the video oculography camera regularly, because the thing is that it is so subtle, the torsional component is so subtle that you can make out the side only after this. This is a patient around 38-year-old, left Dix-Hallpike. You see there is a very subtle, slow downbeating nystagmus, which is left torsional. The first half of the video, I treated him with multiple QLRMs, demi-cement maneuver.
This posterior canal can be quite vigorous nystagmus also.
Yeah, but this apogeotropic was very, very weak. And next day, when I treated and called him next day, I think there's some, it is hanging on.
One more point is that often when you are repositioning a typical posterior canal BPPV, sometimes halfway it gets converted into this epigeotropic type.
Yeah, that's a paper there. So next day when he came, I did a enhanced head hanging position.
Have you put a video of the Demi-Simont? Otherwise, put that also in your YouTube thing.
This was just for the initial part. I'm playing it once now. The first part of the video is showing the downfitting nystagmus with left torsion. So left torsion means that he has got a right-sided apogeotropic or posterior semicircular canal BPPV. So I treated him with the multiple QLRMs. And next day, I did a straight head hanging test because that is the gold standard for evaluating posterior semicircular. And you can see there is a upbeating nystagmus now. Clear cut. Now it is right torsional. Can you make it out?
Yeah, now it's become typical.
So there is an intracannular switch from the non-ampullary arm into the periampullary location. So yes, it has converted into. So once it is there and it converts into the typical posterior semicircular canal BPPV, it is the definite grade as per the Califano's classification. He says that if it converts to typical, it is the definite, and if it is possible is when it resolves directly. So again, the important point is here, in such patients, it is ever better to do a Simon's maneuver or a QLR even for the typical posterior semicircular canal BPPV, because they are likely to have a canal jam in the non-ampullary region. So the more fast you do, you are likely to overcome that canal jam. So this finishes my presentation for today.
Ajay, can I ask you one small thing? Let's say, how do we explain the truncal ataxia? Because from a semicircular canal stimulation, whatever form be it, we don't expect any truncal ataxia. So how can a stimulation in the semicircular canal lead to any type of a truncal ataxia?
Can I say something?
Yes, please.
When we treat, even normally when we are treating a posterior canal, when they come up and when you are treating it, when the particles go into the vertical canal, often it stimulates you. The patient often moves, they get that shaky feeling, they feel as if it's going. So when sometimes patients don't feel spinning, I mean, you will not get the nystagmus, but they will shake. And I don't know whether that truncal ataxia is more of that, shaking, because they have symptoms during that time. Ajay, what do you think? What is this truncal ataxia?
I don't have answers, but you can see one thing. Many patients, when we reposition after the apply maneuver, when they are uprighted to the short sitting position, they have a severe anteroposterior truncal oscillation. I think this could be related to the differentials or sudden increase or decrease in the weight of the utricle, or this could be also. But these truncal oscillations have been documented by posterography, so there cannot be any doubt about that.
Yeah, Dr. Vishal Pawar also wants to say something. Can you unmute him?
I can't. Mansi, can you do it?
Yes, I'll just do it. Just give me 1 minute.
So by truncal ataxia, Anirban, it is just these patients feel very shaky and unsteady, and they feel very scared at that time. Because so, like Dr. Vishal also thinks that it is not in the canal, you are not getting nystagmus, but you are getting, the patient gets sometimes that upbeating nystagmus, and at that time he may shake. So some of the studies of subjective BPPV did not have the earlier ones, they did not do such detailed oculometry, and they did not check the VNG at that time. But now that Ajay Vats and Stocko's article also, many of these patients have nystagmus. So you can't really say it is subjective. You do see nystagmus on sitting up.
Yeah.
Vishal,
So that does make a lot of definite sense. Only thing was that from the semicircular canal, we do not expect otherwise any truncal ataxia. So, but then anyway, this makes definitely, it does make sense. And also the utricle getting stimulated is also not the reason, because had the particles gone into the utricle, then the vertigo would have
agreed. Yes,
and also we do not have evidence to show that putting particles back into the utricle will always cause any ataxia or anything. So a lot of things are unknown, and we cannot explain each and everything related to the findings and symptoms of BPPV. But then now that we are recording the nystagmus, seeing the nystagmus with the video frenzel, I believe we are in a much better position to analyze what is happening. Because without this, sitting up vertigo, by the clinical test, we would practically never have picked up.
Yeah, sir, because it was only after the Stocko's paper that I started seeing the oculomotor patterns on getting up from the Rex-Alpine position, and also I would do a half-alpine position if I see in the nystagmus of more than 1 minute duration. The first thing is that the half-alpine, how many of you do in routine neurological practice? I don't think any of you do routinely in the neurological practice.
No, I must confess that we have seen number of patients who have symptoms on sitting up, and you just see 1 or 2 beats, but have not paid attention to those beats like you have, and you've really done a good job. Excellent work. Vishal wanted to say something. Vishal, unmute yourself.
Yeah, good evening, everyone. Yeah, first of all, it was amazing talk, and many doubts got cleared because of this talk. And that question regarding whether why the patient is not getting nystagmus and patient is getting truncal ataxia. Yes, Dr. Ajay sir explained that it is not moving in the semicircular canal. The canalith, if it moves in the semicircular canal, then it will lead to a nystagmus according to the canal particular stimulation or inhibition. But it is transiently changing the pressure inside the utricle. That's why patient is feeling truncal ataxia, and patient feels truncal ataxia. That's a very good explanation given by Ajay sir, actually.
Yeah, Dr. Madhusudan also wanted to say something. Manasi, can you unmute him? Anybody wants to say anything, please raise your hand so that Manasi will know and she can unmute.
Dr. Ajay, excellent presentation. In your criteria that you have proposed, no? You have put probable, then possible, and then definite.
Yeah.
So in the more objective criteria, whether we should give as probable.
Yeah, the more objective and practical are probable. The practical criteria, they're always there in the Benign Society's criteria, and they are just for the research purpose, those who want to do research in that. We are half researchers, more of a clinicians, less of the researchers. For the clinical purposes, probable is just enough to treat and do.
Mansi, please unmute Dr. Madhusudan.
Yeah, can you hear me?
Yes, sir, I can hear you, sir.
Ajay, it was a really wonderful talk. Always enjoyed your talk.
Thank you,
regarding two things. One thing is the subjective vertigo without nystagmus can be due to utricular dysfunction, as Paul was telling. Sometimes even after repositioning maneuvers, the particle may be moving inside the utricle, causing some, before getting adherent to the matrix. So that change can produce a levitational problem, can produce ataxia.
Yes, secondly, that is sometimes very severe, and the patients tend to fall either forward or backward during that time.
The utricular dysfunction will not produce nystagmus. As Ajay was telling, the nystagmus occurs only with the semicircular dysfunction.
Yes.
Second point is that the so-called truncal ataxia is due to the defective asymmetrical vestibular spinal input to the postural maintenance because of the asymmetrical input from the semisecondary canals, which maintain the equilibrium. That is why they get truncal ataxia-like phenomena after this thing.
Perfect, sir. I never had so much of lateral thinking, but your explanation is more justifiable, sir.
Yes. I
Thank
think
you.
that must be the explanation. But I think we should all now pay more attention to those patients who come with sitting up. One more thing, since everybody here is BPPV people, I have found that if somebody comes to me with a history that he tried to get up in the morning and was thrown backwards, again tried to get up and is thrown backwards into the bed because of vertigo, most of these are posterior canal BPPVs. And they are typically very severe posterior canal BPPVs. The patient tries to get up in bed and he's literally thrown backwards back into the bed. So they turn out to have posterior canal.
Yes, sir. Mostly it is posterior canal because in horizontal canal, this phenomenon I have not seen even after repositioning with the Goffoni maneuver, which I usually use. Yes. When I make them upright from the position 2 of the Goffoni, they don't have such a great ataxia of the trunk, that is the Tomarkin-like phenomenon. It is more common in patients with posterior canal BPPV.
Yes. So, just for fun now, it's nice to try to guess which canal is affected from the history before the patient you put on the VNG. And if you find somebody gives this history that he tried to get up in the morning and was thrown back. He tried to get up and was thrown and then gradually they lifted him up and made him sit. Often these will be posterior canal. Just check it out next time somebody comes with that history.
Yeah.
That is always.
I agree.
100% correct, Sudhir.
Okay, I think very nice talk. We enjoyed. Somebody has written about Dr. Partharay is asking role of high resolution MRI 70, etc. But MRI, in whatever I remember or whatever I have read, it cannot show the particles where they are or what it is, and you cannot really correlate MRI with BPPV. So, has anybody read any articles on can MRI show the particles?
No, they cannot show the particles. They can show the abnormal anatomy of the canals.
Yes. Okay, and one more thing that we all need to remember is that the canals in most of our diagrams look very nice and smooth, and but they are not like that. They're very irregular, and often it's not easy for the particles to fall. So this canal jam, partial, incomplete, or complete jam is not uncommon. So the particles don't just slide up and down very easily. Anirban must have opened some patients with canals. How do you find the canal inside? Can you tell us?
No, I have never opened. I do not have any access to that. But the thing is, they definitely do move inside. That evidence is there in literature. So that nobody is disputing. So that is there. But then what happens to the particles once they are in the utricle? Whether movement of the particles inside the utricle at all cause anything or not, this is all conjectural. Nothing definite has been proven about what happens to the particles inside the canal. But then, as regards the canal, whatever Ajay said and what all of us agreed to, that this canal jam, particles being there in the posterior, in the short arm, in the periampullary region, this does give a very logical explanation to a lot of things that we cannot account for.
Okay, I think this is a nice thing. We should have these neurotology subsection meetings once in a while. Maybe we can show some other cases, central also. I had one very interesting patient yesterday. One of the main big neurosurgeons in my hospital, he came with short attacks of positional vertigo, and whether it was BPPV or not, and as it turned out, it was not positional. I won't tell you what it was, but I will show these cases. Maybe we'll have another meeting sometime next month or something like that.
This was wrong view, but Sudhir, I was waiting for these papers to publish because I just don't want to say anything before the things are already on papers. Once they are in papers and our cases are published, it's safe to show this. So that's why it was delayed for this reason. Because what I have showed is my own research, and it's not from cut copy paste from anywhere else.
No, I must say you are really doing excellent work and keep it up.
Thank you, sir. Thank you.
Okay. Bye, everybody.
100%.
Bye.
Bye.
Thank you.
Bye. Good day.
Thank you. Good day.
Thank you. Thank you, Vishal.
Bye. Bye.
Yes.
Thank you.
Happy
Bye.
Puja.
Yeah. Bye.
Bye.
Somebody